Hello, oral surgery colleagues, and welcome to the Oral Surgery Podcast. I am your host, Dr. Richard Moore, an oral surgeon based in the United Kingdom. The aim of this podcast channel is to discuss ways of improving practice in oral surgery, thereby creating a better journey and patient experience, and allowing us as clinicians to become better oral surgeons. All discussions on this channel are based on personal experience and opinions, which should be thought-provoking and supplemented with further research and evidence-based practice. Without further ado, let's jump into this podcast. Hello everybody and welcome to this podcast. I'm delighted to have Dr. Wendy Thompson with me today, who is an NIHR Clinical Lecturer in Primary Dental Care at the University of Manchester. So welcome, Wendy.
Thank you very much.
It's a pleasure to have you. I first met you, I can't remember how many years ago, probably 4-ish, when you were doing your PhD at Leeds.
Yeah, absolutely. It's I think you were just starting out in your PhD and I was just finishing mine.
Yeah.
So yeah.
Very envious, mine's still dragging on. But it's great to have you here. And I think just for our listeners, because you've got such a unique background, if in a nutshell you could just tell everybody perhaps your story from first degree to where you are now.
Yeah, okay. So my first degree was microbiology degree, straight out of my A-levels, as everyone does, at the University of Warwick. And I then went to work down in Whitehall as a scientist for 10 years there or thereabouts, bit of mat leave in the middle of it. And didn't touch anything to do with microbiology at all the times I was there. I was doing things like buying aircraft carriers and
that sounds
missile
exciting.
defense, a whole range of different stuff, which is interesting, and you'll see how it all links in later on. And then my daughter was born and my husband came out of the army and we decided to move back north again. I'm from Lancashire originally. We moved back to the area. And that was an opportunity really to take stock. I was in my early 30s, which way next? What is it that I want to do? They don't have Whitehall scientists in Lancashire, so what am I going to do? And the opportunity arose. And I think that's one of the things I'm going to say is that luck comes to those people who are open to the opportunity. And I've been really lucky, really, really lucky since I had the opportunity to do dentistry on this brand new course at UCLan. With a dental education centre less than 10 miles down the road from home. When does that happen?
Oh, so you could just roll out of bed.
Yeah, well, kind of, but yeah, it was closer than going to Manchester, which is what I'd originally been thinking I might have to do when I was looking at dentistry. So after moving to Lancashire and this opportunity arose to do dentistry, I took it. I loved it. I did well on the course, and I went out and did my foundation dentistry. Now, it's just 10 years ago this year that I did my foundation dentistry up in the south of Cumbria. I'm a country girl, and working in a country practice, it reminds me of the old all creatures great and small, the kind of practice we're in.
Yeah, or peak practice.
If a farmer calls up and says they've got toothache, they've really got toothache and you really need to see them now. It's because it's a different style of dentistry, but I love it. It's me. And when I did my reflections as an undergrad and when I still do them now, they almost all finish and then the patient smiled. And for me, it's that buzz you get when you've made a difference for somebody, when they came in pain or when they came in with teeth that they weren't happy with, and you've been able to do not just their teeth, but you've made a difference to them as a person and their personality. That's the smiling thing. It isn't just a physical thing. It's a whole emotional that goes with it. And when I finished my foundation, or when I was doing my foundation dentistry, actually, we did an audit. We did about antimicrobial prescribing, and obviously, with having a microbiology degree, that fits with me. And having a Whitehall background, when I was writing it up, I was kind of feeling that there was a bigger picture going on here, and that it wasn't just about some clinical guidelines that people were or weren't following, but there was a whole scope of stuff. So when I wrote my report up, I wrote it like a government report, really. And it got picked up and shown to a few people. And from there, I was invited on to apply to be on a NICE committee about antimicrobial stewardship. And then from there, someone said, well, you should think about doing a PhD. And here's my next lucky step. I went, me do a PhD, get out of here. Don't be stupid.
But when you did that first audit, were the findings astonishing to you or unsurprising? because you're obviously quite junior in your
Yeah,
dental
very junior
career.
in my dental career, and I guess I didn't really know what I was going to find. Um,
Okay. What
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 did we
did you
find?
find
We
that people
found
were
that there
just
was a very big difference between practices. Some practices, there was a
right?
lot of antibiotic prescribing going on, and some there was hardly any. But I did my foundation training up in health education northeast, because South
Okay.
Cumbria at the time was part of that area. So I was getting to look at prescriptions from practices up in Blythe and places I have no clue where they are.
Yeah.
I know that Blythe's absolutely beautiful in the countryside around it, and not so beautiful in the town itself. But other than that, you know, I didn't know whether they're appropriate prescribing or not appropriate prescribing, so I
Yeah.
couldn't really make a
Okay.
judgment on it. But from getting involved at the policy level, if you like, and someone saying, well, you should do a PhD, that night, literally, I got home, opened my British Dental Journal up, and there was an advert from University of Leeds for these anniversary research scholarships,
Wow.
and it had my name written all over it.
It was meant to
As I
be.
say, this whole thing about luck coming to those people who are open to the opportunity.
Yeah.
So I applied for it and got it with it was a lady called Julie Burke. You probably know Julie. She's up in
Yeah, I
Scotland
know
now.
Julie
Yeah,
really
so she
well.
was
Yeah.
my supervisor at the time, and then within 3 months of joining Leeds, she came to me and said, "Wendy, I've got something to tell you. I'm
I'm
leaving."
leaving.
so so Gail Douglas became my first supervisor. She's dental public health, and
Yeah.
then
Who's my
oh,
supervisor? Or one of my super? Yeah. So I know Gail
fabulous,
really well
yeah.
as well.
And then Sue Pavitt was one of my was one of the other supervisors as well. So Sue is a methodologist. She's worked in dental
Mm.
schools around the country, and she is a big cheese in the NIHR National Institute for Health Research. She heads up, well, she didn't at the time, but she does now, heads up the oral and dental research portfolio.
Yeah.
I mean, she helped me apply for a doctoral research fellowship, which was worth about £330,000, I think it was. So it paid me to be a salaried dentist. Um, so it paid my salary as a dentist and to do the research. And
Yeah.
it allowed me to work 1 day a week in practice. I found it really difficult working just 1 day a week in practice. You kind of, it's not great for patients because they can only see you one day a week. If something happens, other people have to pick up your problems.
Yeah.
But
Yeah.
the other thing was that you kind of, you wouldn't see very much of it sounds kind of strange, really. You can't get started if you like 1 day a week. I do 2 days at the moment, and it's a lot better. And
Mm.
so, if anyone is thinking about doing a PhD with some clinical time, I would say try and do it. Try and do the research more part time and the academic a bit more than 1 day a week, probably 2 days a week, and that gives you more time for your academic work because when you're applying for all the approvals and all of the there is so much admin that goes on when you do
Mm.
research that it just
Yeah.
gives you more time. It isn't you that takes it isn't your own personal time that takes a lot of time with the admin. It's submitting paper for this and then it goes through committee after committee until it finally comes back to you. So it takes 6 months for something to happen, then that's a long time out of your 3 year PhD. But if you're doing it
Yeah.
50% time on 50% full-time equivalent as your PhD, then that's a 6 year PhD. That 6 months for your approvals is like a lot less of an impact on what you're doing.
Yeah.
So that's what I would that's my learning really from doing the PhD. So yeah, so I got an NIHR grant to or a doctoral research fellowship, and the title of my PhD is Antibiotic Prescribing Towards a Reduction During Urgent Dental Care in England. And in hindsight, it's the most ironic title in the world because I graduated in December 2019. And within 3 months, antibiotic prescribing in dentistry in England had gone up by 25% rather than down.
Yeah. I'm surprised it was only 25%, to be
Yeah,
honest, but
in Scotland it was a lot more,
it's probably
but in
yeah.
England it was 25%. Yeah, for those 3 months, and then it's been steadily, very very slowly, but steadily coming down back to
Okay.
pre-pandemic levels again,
So
which
that's a
is a
good
good
sign,
sign.
isn't it? It's,
And so as part of my research, I started off by doing a systematic review because all good PhDs start with a systematic review to tell you what's already out there in the literature. My systematic review was saying what factors are associated with the decision whether to prescribe an antibiotic. I wasn't interested in what antibiotic was being prescribed, because actually, if someone's
Okay.
taken an antibiotic, if you if they've experienced an antibiotic, then their microbiome, their bacterial flora around them will have changed. It will have resistant bugs in it, even if you only take one
Yeah.
dose. So you're better off taking none at all than, and it doesn't, the
Okay.
actual antibiotic that you take, it is important because there's different drug bug combinations that are resistant.
Yeah.
But it's the decision whether to prescribe at all, which is more important. So there's about
Okay.
80% overprescribing of antibiotics in dentistry.
And do you think that's still 80% now, or that was before, during
Well,
your
that was
PhD?
a study that Anwyn Cope did about 2016, I think it was, and it came down a
Okay.
bit from that, but nowhere near the 80% that she found over. And,
And do you think that's
and then, so what I was going to say was, and during
I was-
COVID, we went back up to that 2016 level. So
yeah.
yeah,
And do you think that's comparable in medicine?
medicine's a lot lower overprescribing.
Mhm.
Yeah.
You see, anecdotally, you kind of feel it's the other way, don't you? Well, I do. Could be
Yeah, it
completely
might be
wrong
the
with that.
context that you're working in, Richard.
Yeah,
So
probably.
it's
Because I think primary care dentistry is obviously very different to secondary care.
yeah, and it's the
And
urgent dental
yeah, yeah,
system as well. So it isn't just what's happening in routine dental practices. They're lower
yeah,
prescribers. It's what goes on in the urgent dental clinics themselves. So,
yeah,
so the factors, it won't surprise you to know there were a whole range of factors, because if it was just a simple issue with one or two factors, then you can solve that. But we found
yeah.
about 28 factors that was in the literature.
Wow.
Um, and what we did, we said, when I started doing the PhD, there was hardly anything in the literature about dentistry. So we started off doing a systematic review that looked at primary care medicine and primary care dentistry, and then compared and contrasted them. And by the time we'd finished doing this, doing the systematic review searches and analysis for a start, we found there'd been some more dental studies published. So we redid it again. So we ended up with quite a substantial review. So yeah, 28 factors, potentially modifiable factors. There were some that weren't modifiable as well. So things like the patient age and gender, things like
Yeah,
whether the practice is rural or urban. You can't do anything about that. They do affect the rate of antibiotic prescribing in different countries as well, because a systematic review isn't just in the UK. So
yeah.
then I
Okay.
looked at the factors and I said, yeah, some of them, especially some of the dental interview studies, it just kind of smacked to me of um, someone who wasn't a dentist interviewing someone who was a dentist and being told, well, the reason is, and then not having the background to really, the insight to understand what was being said to them or to challenge what was
Mm.
being said to them, maybe. They just took it as read that it was okay and that it was relevant. So what I wanted to do was an ethnographic study. So what you do on an ethnographic study is you watch what actually happens. You don't poke the subjects to see what happens if you poke them. You literally just watch and you say what happens normally. Now, purely and simply, the fact of you being there watching means that people might change their behaviour
Yeah. Practices.
through the Hawthorne effect. But actually, urgent dental appointments are so short that there's not much time to change what you would normally have done. And that's what we found, pretty much. We knew that we were going to find clinical practice that wasn't directly in line with guidelines. And we wanted to be able to see that because we want to see why people are overprescribing. We didn't want to put them off doing what they would normally do. And
Yeah.
so we thought really carefully about how to do the ethics of this. So, getting the ethical approval was quite interesting. Normally, when you're getting ethical approval for a subject, for a study, you need to give participants a couple of days to think about whether they want to participate before they go ahead. But in an urgent dental setting, you can't, because you don't know who's going to come in with toothache in 2 days' time. So we had to find a different way of doing that. And the Yeah, so the ethics of doing this, we needed to make sure that it was okay for the clinicians to be watched and observed and not feel that they might be dobbed in it to their managers or to the GDC or
Sure.
whoever. And so we thought really carefully about this, and I spoke to the GDC and I spoke to uh, various people around the net about how to do this. And what they told me was, don't see a pattern of behaviour. because you would only need to report it if you saw a pattern, and a pattern is 3. So don't see it 3 times. So what we did, we audio recorded, because you don't know who's going to be turning up with toothache when, so you can't just sit there and watch all the time just in case someone turns up. So in the general dental practice setting, we just audio recorded the appointments, and it was the practices who did it themselves. We trained them on how to set the recordings up in the right way for us. And in the out of hours dental settings, we got them to audio record them, but we also had some sessions where we actually had someone sitting in the appointments watching. But again, they couldn't be a dental registrant because they couldn't see something actually happen. Because if a dental registrant sees something wrong going on, then they need to step in and say, no, that's wrong.
Sure.
So we needed to
Yeah.
make sure that the person observing was also safe, and that I, as a researcher, was safe. So we audio recorded appointments. We audio recorded about 10 appointments per dentist. And then we just selected, off the basis of some outline information that they gave us about each of the appointments, what treatment they'd done, and then they had an opportunity to write a little comments at the bottom of the sheet that they were leaving us. And we selected using a sampling strategy to get a full range of different kinds of patients and clinical situations. And so for each dentist, we only saw 2 patients. We only followed up with 2 patients.
Okay.
So we did follow-up interviews with the dentist and with the patient and with a dental nurse, to understand what we'd heard on the transcripts for those particular appointments. And that's enabled us to see all of those 28 factors that we'd seen from the systematic review, plus another 4 factors that hadn't been reported in the literature before.
Okay,
Yeah,
that's interesting.
and from those factors, we'd mapped them over to a behavioural framework called the COM-B model. So COM-B means if you want to change behaviour, that's the B. Then you have 3 things to look at, the COM bit of it. So C is capability. That means their ability to do the skill. Do they have the skill? Do they have the knowledge? Do they have the there's a whole range of things around capability. O is for opportunity. So do they have the time to do it, the opportunity to do it during the appointment? Do they have the equipment to do it? Do they have the setting to do it? So that's O for opportunity. And M is motivation. And can I swear on this? No.
Probably not.
Okay, I'll take that. Do they? So the motivation is: do they really want to give antibiotics, or do they really not want to give antibiotics? What's their personal motivation? What are their beliefs about the risks and the benefits of antibiotics? And so that's the COM-B model in short for you. So we've mapped all of those 32 factors now onto the COM-B model. And here's where we started bringing in the patients and public and members of the dental team to help us sort through that list of 32 and decide, well, which factors of these are we actually going to work into an intervention? And I'd started thinking around this sort of time again about shared decision-making, consent, in urgent during routine dental appointments. You say to people, you say to dentists, do you consent your patients before you do treatment? And they say, of course I do. And you say, do you consent them before antibiotics? And they go, do you explain the risks and the benefits to them before prescribing an antibiotic? And they don't. And
No.
it's not something we're kind of taught to do, but it really needs to be. It's a treatment, and they have risks
It
associated
is a treatment,
with them. And especially if it's something like implants, which I know as oral surgeons you'll be really interested in. Implants is help me out, Richard. What's the word I'm looking for? An elective treatment. So placing implants is an elective treatment. So people have time to think about whether they want to have them done in a particular way, a particular kind of implant. And they also should be having the opportunity to think about the risks and benefits of antibiotics as part of that treatment.
It's interesting you say that, because I generally do give an antibiotic dose before the implant, but I will talk to the patient and say, I'm going to offer you this. There's no evidence really. Well, there's probably more evidence to say you don't need to give it, but it makes me feel better. And I'll probably sleep better tonight. And I think you probably would. And if I was having an implant, I think I might want just that one
Mm.
dose. You can probably shoot me down now, having said that. And I know that Robbie Williams did his MSc in this as well, who's hopefully going to come and speak on the podcast about antibiotics. And because, the general consensus of people is, well, we'll give them one dose and it'll be fine. And it's usually 2 grams of amoxicillin. But actually, do we really need to do that? But then if that implant fails and you haven't given the antibiotic, are we practicing defensive dentistry? And we probably are, because, I think people are worried about, am I negligent by not giving it? If it fails, is the patient, going to raise a
Yeah,
complaint,
so
etc.?
it's
So
interesting, isn't
it's
it? I mean,
tricky.
there it's defensive dentistry either way, and it's really, really difficult to know, and it's really a case of
Yeah.
explaining the risks and benefits to the patients, and
Mm.
it's hard.
But I've not had a patient yet say, no, I don't want
Have you had a patient
antibiotics.
yet come back to you and say they've had C. diff infection afterwards? Or
No, not yet.
yeah,
But time will
yes.
tell. And I'm guessing with a single dose of amoxicillin, I know the risk is still there, but it's probably, well, I'm hoping you're going to say it's the lowest risk for the lowest with that
So
antibiotic.
there's
But
cases in the literature now, and not just in the literature, but cases that are going through medical legally where people are coming to the well. So there's one case I'm
yeah,
thinking of in particular, from down south, and the patient said after it was all cleared up and it had gone through the medical legal thing, why didn't you tell me that could happen? I would probably still have had
yeah,
antibiotics, but at least I'd have known what it was.
I knew. Yeah. It's so difficult, isn't it? Because you just feel that everything's against you as a
Yeah,
clinician, and the challenges are just
yeah,
mounting up. But I think the shared decision making is so
yeah.
important, and I totally agree
So
with
I'd
you on that.
started,
That for any
yeah.
part of
So I'd
dentistry, yeah,
started thinking about shared decision making while I was going through all of these factors with the patients. It was a lot of them were looking like the kind of things where it was about talking to patients really. And during urgent dental appointments, you don't have an awful lot of time to talk to patients, do
no,
you?
yeah,
And so
no,
I started
no,
asking, the whole Montgomery thing as well. You're supposed to find out whether
yeah,
they play the trombone and whether they've got a particular concert tonight or tomorrow that might be particularly important that you can do it today rather than tomorrow, and all that sort of stuff. And uh, so because I'd sat on a nice committee before, uh, I contacted a friend because I'd read a nice something that Nice had written, and I just said, "How does Montgomery fit into all of this?" And they kind of went, "Montgomery," and I went, "Yeah, yeah,
who's that?
Montgomery links to," because in their heads, shared decision making and consent were two separate things. Um, as we went through and I
Right,
became a member of the guideline development group for it, and as it went through the guideline, well, when you read the guideline now, it does talk about Montgomery in there. But in dentistry, we're a lot further ahead of the curve than the medics are in terms of consenting people, because we're surgeons. We're doing surgery on people, irreversible things, and so therefore the consent that we get from people before every procedure we do is something that medics tend not to do. Medics are just tending to talk to people.
yeah. And I wonder how many GPs would, and this is no disrespect to GPs, but the antibiotic they give out, do they consent the
No,
patient for that? And again, it's time as
yeah.
well, isn't it?
So GPs will do a
It's
lot less consent than dentists do, just because of the nature
yeah,
of the beast. And when I was doing that
yeah,
systematic review, there were two factors that were different between dentistry and medicine, um, a GP, sorry, and the issues were both around the fact that we are surgeons, dental surgeons, and it
mm,
was whether we felt that we had the ability to get on and do the uh, procedure during an urgent dental appointment rather than just giving an antibiotic.
yeah,
So I developed a shared decision making intervention as part of my PhD. Did it with patients and with dental teams, and that is now we've got a funding application at the moment again to the National Institute for Health Research, Research for Patient Benefit Fund, and I'm waiting at the
oh,
moment to
excellent.
hear whether we've got through stage one of that application to be able to then go ahead and uh, evaluate. So the first stage of doing a clinical trial isn't to go ahead and do the clinical trial. The first stage is to say, is it feasible to do a clinical trial on this? And because there's a whole range of different factors that might or might not work for it. And so rather than spending the many millions of pounds of clinical trial costs, you just spend a few £100,000 doing your feasibility study. So that's the stage I'm at the
Okay.
moment. Yeah.
Oh, that's good. That's excellent. I mean, it's just opened so many doors, the PhD, hasn't it? And that. But I think that interest that you had from day one, and the drive, particularly of being a mature student through dentistry, is probably not half the battle, but certainly significant to
Yeah,
you.
so I remember because I went through UCLan, it's a postgraduate course, and so
Yeah,
everyone comes
yeah,
with a bit of background or something a bit different. And I
yeah,
just think that we have to remember that we're not just dentists. Dentistry is what we do in the day job, but we are
yeah,
people in the wider world, and people bring lots of different things to the table with them when they come into dentistry. And some people have different passions as well. I enjoy the uh, that thing of looking at the bigger picture. So I
yeah.
started off with NICE, and then I'm now on the BDA's Health and Science Committee, and I'm on the FDI Science Committee. I was elected in the summer to FDI World Dental Federation's Science Committee, and I'm chair of their antimicrobial working group. So, you push one door or you open one door and then the next one swings open
Yeah,
as well. And
yeah,
and that PhD was an important part of it, but it wasn't the whole. There'll be a
yeah,
whole load of people who've done PhDs who don't get those sorts of opportunities. It's
yeah,
having those lucky breaks. It's saying
definitely.
yes to things that you think, really, me do that? No, come on.
Yeah, yeah.
But
Uh,
give it a go.
uh, and we mustn't forget that you've been nominated in the top 50.
Yeah,
I
apparently.
don't know what's the official title. I saw it on Twitter, but
Yeah,
I
I have
didn't.
no idea where that came from. Apparently, in previous years, they have asked people just to nominate and vote for whoever they wanted to be the top 50. Is it the most influential dentist? I don't know, something like that.
So, oh, that was it. Yeah, yeah. I
Yeah.
did have a chuckle, but
But,
not that it's not
but
deserving.
I think they've got like 96 names on the list this year that they wanted people to select
Oh,
from.
okay. Well,
Um,
you've got to
But
be in
I
it to
like
win it.
so I didn't know anything at all about it before I saw it online and people started messaging me. But if you look at the big picture of it, where they've got like a composite of all the little head and neck
Yeah,
pictures,
the face. Yeah,
I'm bottom left, or sorry, bottom right of the picture, which to me looks like a lower left wisdom tooth, which is
always
yeah, exactly.
troublesome. So I guess leading on from that, and especially with COVID, this is probably quite timely, isn't it? You said earlier that antibiotic prescribing just shot up, and that, I mean, the AAA advice was that was what we were told to, or certainly, I mean, not me because I was in secondary care, but certainly in primary care for UDCs, that was the only option,
Yeah,
really,
it was an
wasn't it?
incredibly
Or one of
difficult
the,
time. I mean, so the bottom line was that the government didn't have enough PPE to go around for dentists to have them as well. We weren't prioritised as people who needed PPE, so therefore they needed to shut practices down and restrict dentistry. So we were working remotely. And when you're working remotely, it's really
yeah,
hard to
it's really
diagnose
difficult.
what
Yeah,
someone's got, and it's even harder to treat them once you think you know what the diagnosis is.
yeah, yeah,
And because dentistry is a face-to-face, hands-on surgical profession, we're not like GPs. GP is Even my GP colleagues tell me it's very difficult to make the call on. I was talking to a GP, one of the academic GPs at Manchester the other day, and he was saying that he had a patient who was pregnant who'd called it with X, Y, and Z, and he thought it was probably just something that needed a bit of advice. But if she, oh no, he'd prescribed something. I can't remember what he'd prescribed to her, but he said if she'd been there in the surgery, he'd have looked in the back of her eyes, and he didn't look in the back of her eyes, and he felt like he was working in a
yeah.
more risky
It's
way than he is
yeah,
used to.
yeah.
And that's how it felt to
It's
us as
so
well, wasn't
difficult,
it?
isn't it?
So, I mean, my
Yeah,
antibiotic prescribing probably doubled or even tripled during COVID. And by that, what I mean is that where I'd normally prescribe about 2 antibiotics in a year, I probably prescribed 5 or 6.
mm,
So, and that was me still working 2 days a week through it.
yeah,
So, we had a lot of patients calling up.
yeah,
We were seeing people off the NHS 111 list as well, because in South Cumbria we've always had a massive shortage of dentists. You've probably seen some of the stuff about access to rural dentistry
yeah,
from.
yeah. Which is crazy because it's such an. I mean, I was in the Lakes last week. It's such a gorgeous part of the world, isn't it?
Yeah, it is,
And
but it comes down to that thing I was saying about you've got a life outside of dentistry as well, and
yeah,
you might have seen the
yeah,
paper.
it's not for
It,
everybody,
it
is it?
really isn't, and if you select people, dental schools select people from the best with the best A-level results, they're probably not from some of the more rural areas. And so then when they come out to go and people try and get them to go and work in rural areas, they go, do you know what? This isn't me. I'm not from a rural area. So, take the golden handshake and then go back to, it happens in medicine as well, and it happens in other countries. It's not just in UK. So we need to be looking at recruiting people from rural areas into dental schools.
And retention, really, isn't it? Once you've got them, keep them.
Because once they go into dental schools, they, like I did, you go and work in London for a while, but then you go back to where home is. And
cities are not for everybody,
absolutely,
are they? It's but it is variable, yeah. So I guess leading on from all of that, trying to sway you over to the oral surgery side. We've touched on the implant issue a little bit, and it's so difficult. I think we definitely prescribe less. When I was a houseman, everybody having their whizzies out would get a shot of coamoxiclav on the table and the 7-day course, and that was protocol. It doesn't matter what was wrong with the patient; everybody got that, and obviously that's a bit of an issue. But I think nowadays I'm really not reluctant to prescribe antibiotics, but if I've got a good clinical reason. And again, particularly wisdom teeth, our registrars will say, "Oh, that was really hard, Richard. Do you think we should give some antibiotics?" I'm like, well, can you justify it? And if you don't, they come back on Monday after a Friday list with a big fat face and pus. Do you think, would that one dose of antibiotic made a difference? So I think we do think. Certainly, our undergraduates, we do drill it into them that you really must have a good reason to give an antibiotic, and the same with our registrars. But there is a time and a place where we have to, and we noticed as we were chatting earlier before we came online that there was a bit of and I'm going to be naive and honest. I thought the protocol now first line treatment was not amoxicillin, but it was penicillin V, and the only time I ever used that was when I was doing an ENT job. And that was tonsillectomies, tonsillitis, was Pen V. But having chatted to you, I might be slightly off piste here.
Well, sort of, but sort of not. So the FGDP, as you know, is now FGDP and FDS were both part of the Royal College of Surgeons. FDS is still Royal College of Surgeons. FGDP is now CG Dent. And the guidelines were updated. The antibiotic guidelines were updated so that they weren't just about primary dental care, but they covered all of the specialties as well. So oral surgery and everything. And what they say in those guidelines are either amoxicillin or Pen V. So a penicillin-based drug is your first choice. It discusses the pros and cons of both of them. It's the Scottish Health Improvement Scotland. They have a dental antibiotics group which has recommended Pen V for dentists working in Scotland as being the first choice because it has a narrower spectrum. However, SDCEP hasn't changed its guidelines because SDCEP is just BNF. So have I confused you yet? So
no, you've made it clearer because I definitely, and I hold my hands up for spreading that document that came out to all of our trainees and social media. Look, everybody, we need to now use Pen V, and I haven't switched to Pen V. I'll be very honest with you.
So let me
and I don't
tell
know
you
anybody.
what it says in the FGDP FDS update, which was December 2020. Scotland, the Health Improvement Scotland guys were really keen that FDS and FGDP guidelines should swap to recommend Pen V. And their rationale for that is that they are oral microbiologists and they want everything to be as narrow as possible because as microbiologists and infectious diseases specialists, they see the problems of resistant infections that come through the door. So just like with infective endocarditis, it's the cardiologists who see the problem of someone having infective endocarditis, and you as oral surgeons see the problem of someone having, I don't know, osteomyelitis after something's gone on. And so you tend to go with what you see, the feedback you get afterwards, rather than not knowing what's going on. So the infectious diseases and oral microbiologists would like us to go for the narrowest possible spectrum penicillin, which would be Pen V. But Pen V has to be given 4 times a day on an empty stomach.
So your compliance
and 4 times a day
low.
on an empty stomach is actually quite difficult. My mum had to do it the other day for something.
I couldn't do that. I'm always eating.
Yeah, even if you only eat at meal times, it's still actually quite difficult to do it. And
Yeah.
so amoxicillin is a slightly broader spectrum. See, my view on it would be that you should be trying to get rid of that 80% overprescribing. And actually,
Yeah. Rather
the
than,
drug
yeah.
that you're giving is less important.
Yeah. It's the
The
overprescribing's the issue.
overprescribing in the first place is the issue, yeah. And like
Yeah.
you say, just so it's about people just giving themselves that time before they write a prescription to say, is writing a prescription the right thing to do? Does this
Mm.
patient need it? And what happens if something goes wrong for this patient? So it's about the risks to the individual patient. So they could have anaphylaxis. That does happen. And they could have C. diff. That does happen to dental antibiotics as well as um, uh, hospital-based antibiotics.
Yeah.
Um, and obviously antibiotic resistance as well. The thing about resistance is it's massive, and have seen the news in the last few days. The Lancet report says that there are 1.5 or 1.3, I think it was, million deaths attributed to antibiotic resistant infections in 2019. That's a huge number. That's double what the estimates were 5 years ago.
And I think we're just I wouldn't say we're oblivious to it, but you're right. If you don't see it, it doesn't ring any bells,
Exactly.
does it?
So when I'm lecturing, I'll sometimes say, who do you know who suffered from an antibiotic resistant infection? People go,
Yeah.
don't know. Who's had someone close to them who's had cancer and died from cancer? And they say, oh, yeah. So did they die from
Yeah.
cancer, or did they die from the infection that they had while were having the cancer
And the
treatment,
answer,
because
yeah,
they're immune
yeah,
compromised, and they've had to have antibiotic after antibiotic after antibiotic for the pneumonia, the urinary tract infection, whatever it is. Very often people die with cancer, but from a resistant infection. And
yeah, yeah,
the medics who are certifying death are reluctant to write antibiotic resistance on the death
mm,
certificate, because it impacts on their practice, on their practice, on their
yeah,
hospital. Those figures start
yeah,
adding up, and they don't know that it was the resistant infection. Maybe it was the cancer that took them rather than the infection.
yeah. It's
Yeah,
difficult
it's
to
a lot like
prove,
the
isn't it?
COVID deaths. Did
Yeah.
they die
Oh,
with
yeah.
COVID or of COVID? And how do you tell the difference? And
Yeah.
so, the figures that we're getting for that are died with COVID tested positive for COVID in the last 30 days before they died.
Yeah.
And I think we'll probably need to go that direction for resistance, because until people start seeing that, oh, look, Auntie Jean died of a resistant infection on the death certificate.
Yeah. You need word to
Yeah,
get out, don't
people
you?
need,
And
so the
it being,
Wellcome Trust call it a sense of personal jeopardy. You need to think that it's something that could happen to me. Well, I mean, antibiotic resistance could happen to you, your friends, or your family, is the phrase that we're
mm,
encouraged to use.
yeah,
But you don't really feel that until you start seeing it. It's like COVID, isn't it? You start seeing it happening
yeah,
to people
definitely.
around you, and you go, "Oh, this is getting a bit real."
Yeah,
Yeah.
definitely. And I guess so that kind of brings me on a little bit to prophylactic antibiotics. And I don't know whether this is your arena
Mm.
or not really, but we've shifted from, and there's so many papers about, do you give prophylactic antibiotics before certain types of surgery? And I think there are a certain group of patients that we would probably agree would need them. But certainly for things like, bone grafting, implants, sinus lifts, surgery that you think is going to involve the sinus, or, patients who've got mouths like ashtrays, do we need to give them something just to try and help us? What's the general? I mean, I can tell you what the oral surgery world thinks, but I think from your perspective, with your research and background, what's the vibe about prophylactic antibiotics? And also, and I don't know if you'll be able to answer this, I was told many years ago by a microbiologist that if you give them an oral dose half an hour before what we would say knife to skin, that's almost as effective as giving them an IV dose.
Oh, I don't know about that bit. Yeah,
Okay, well
yeah,
we'll park that, but the
yeah.
prophylactic
I mean,
stuff,
it would actually.
maybe you could.
You're ringing a bell now on something I read last week, where it was treatment of
Okay,
infective endocarditis, which has always been IV, and they're now saying, actually, do you know what? Oral's just as effective. So it
yeah,
wouldn't
yeah,
surprise me at all. Um,
okay,
Prophylaxis, it's interesting actually. So in the UK, I talked about 80% overprescribing, and that's all
mm,
therapeutic use of antibiotics.
okay,
In America, there are far more prophylactic antibiotics given
Yeah.
than therapeutic antibiotics given in dentistry. And they have a 80% overprescribing, but that's of prophylactic antibiotics.
So that's interesting, isn't it? Because well, is it overprescribing or is it actually preventing
So
I don't
prescribing
know.
not in accordance with guidelines. Yeah.
Right. And are their guidelines as strict as
No,
ours?
no, no, no. And that's why they have an awful lot more prophylactic prescribing than
Yeah.
we do. So
I mean,
they prescribe, just like the rest of the world do apart from UK, they prescribe for infective endocarditis, people at risk of infective endocarditis.
yeah.
But they don't prescribe for, or their guidelines aren't for prescribing for prosthetic joints. And they're not
Okay.
for prescribing for, what was the other one I was going to say? Implants of some sort.
Right. I mean, it's interesting you touch on the infective endocarditis. I think I won't say what I do, but I think the general consensus is to give it with patient involvement in that shared decision making,
Yeah,
even though the guidance says not routinely, because I think, and I don't know if you've ever heard Martin Thornhill
I
speak.
have. Have you heard the Leeds cardiologist speak though on this as well?
Oh no,
Yeah,
this could be like a battle of
yeah.
the
So
greats, couldn't it?
I'm not going to get into the battle of all of that. I just think that the
It's
thing that,
difficult though, isn't it? It's
well, so the
really,
thing that will keep you safe is prescribing in accordance with guidelines. And
yeah.
the
But that word, not routinely,
yeah.
nothing's routine, is it?
So I would say, so there have been a few times in my career where I have offered a patient prophylactic antibiotics. And I have, for one reason or I remember one particular, the patient was on warfarin and X, Y, and Z, and I was like, well, you can't have this and you can't have that.
Yeah,
And the risk of, I think clindamycin was the drug I was going to offer her. And so the risk of clindamycin is obviously it's really linked to C. diff.
C. diff.
And
Yeah,
with my anti-dying in Blackpool Hospital of C. diff, we'll talk about that in a bit if you like, about how the hospitals reduce their C.
yeah,
diff
yeah.
rates by reducing their antibiotic prescribing of certain antibiotics. Then I just said to her, look, should we just do it without? And actually we did it without, which was fine. The bit that wasn't fine, and we
Mm.
did it first thing in the morning, luckily early in the week, but her warfarin had obviously
Okay.
wasn't quite as low on the day that we took the tooth out as the
As the
iron
INR
suggested.
suggested.
Yeah,
Yeah,
exactly. So yeah,
yeah.
that was an interesting one. So yeah, it is
Yeah.
interesting though, on the in America their guidelines, prophylactic guidelines, used to be amoxicillin first choice and clindamycin second choice, not just for
Mm.
prophylaxis, sorry, for everything. And
Right. Okay.
they started noticing, and there's a paper in the literature which related community C. diff rates to dental antibiotic prescribing, because they were
Oh,
really, really high. And the Americans couldn't understand why UK rates of C. diff were so much lower than their rates. And they realised that it's,
interesting.
and again linked to a Martin Thornhill paper, that clindamycin has an associated death rate with it. And if you're giving
Mm.
something for an elective treatment, then you really don't want to be doing something that's got an associated death rate with it, really.
Yeah. Yeah.
So, trying to stopping infective endocarditis by causing C. difficile isn't great,
Yeah.
because these
Yeah.
patients are sick in the first place, which is why there's stuff
Exactly. Yeah.
going on.
Yeah. It's difficult,
So
isn't it?
Blackpool Hospital, which is where my auntie was about 20 years ago now, it must be. And I think you said you worked at Doncaster Hospital as well, which has had a similar strategy at one point.
Mm.
The
Yeah.
rates of C. diff linked to coamoxiclav, to clindamycin, to third generation cephalosporins and ciprofloxacin
Mm.
is so high. I got that right? I think it's ciprofloxacin is so high that in those hospitals, the way that they cut their C. diff rates was by saying that clinicians could only give those particular antibiotics if they had a signature from an oral microbiologist saying that it was
Yeah.
necessary to do
Yeah.
that. And that's interesting, isn't it?
And I was challenged by several colleagues because Comox Lab was the first line, and I brought in guidelines, and it's difficult when you're in a trust because you're dictated to some extent by
Yeah.
the trust and the microbiology guidelines. But certainly at Doncaster, the consultant microbiologists were like, "This drug is not to be prescribed," and And I guess the way my colleagues got around it, as on an outpatient prescription or an FP10, they don't have any jurisdiction over that. Whereas if it's in hospital and it's going through the
Yeah.
system, it was the electronic
So
prescribing system, then you
why
couldn't
did
do
they
it.
think that those patients would benefit from co-amoxiclav over just
I
amoxicillin?
think one is ignorance. One is history. That's just what, and I don't know why. Certainly in my Max Fax training, that was the drug of choice. Whether it's because people feel its spectrum is so broad, it's almost like domestos to the mouth. It will kill anything, and we'll have no problems
Yeah,
with it.
until
But
it
quite
doesn't.
clearly, well, yeah, and also causes issues
Yeah,
elsewhere. So. And I think in hospitals, co-amoxiclav is still quite
yeah, it is.
commonplace. So yeah, so it's interesting that, and I could be wrong here, but I was going to say that general dental practices can't prescribe it on an FP10. Is
No,
that
you can prescribe
it's
it,
not?
but you shouldn't prescribe it. It's not
Oh,
within
okay,
guidelines. So if you're thinking
okay,
about prescribing it, think twice about why you. So the only reason you would want to prescribe co-amoxiclav is if you think that they've got a resistant infection. And if you think they've got a resistant
yeah,
infection, you really need culture and sensitivity testing. And
exactly,
that's not
yeah,
something you do in
yeah,
primary dental care. So if you
no,
think, I mean, why would you think someone's got a resistant infection? It might be because you've given amoxicillin already and it didn't work. Well, that's not the time to
yeah,
be thinking about, oh, I'll try co-amoxiclav, see if that one will work. If
no,
they've got an infection and it's going somewhere, that needs to be seen. And if they've
yeah.
got if they haven't got an infection that's going somewhere, then why do they need antibiotics? It's
Yeah, and you would hope that if they've come back having had a course of antibiotics that you feel was
yeah.
appropriate, that you recognise that for some reason this has failed, whether it's compliance or wrong drug, wrong diagnosis, then you need to be getting somebody else's eyes on that, really, don't you?
Yeah, I had an interesting case a few years ago with a patient that had been given metronidazole for pericoronitis from a colleague, and the they came back 3 days later. It was a Saturday. I was working the Saturday, and I was the only dentist in. So they came to see me, and they said 3 days later, maybe 4 days later, the metronidazole's not working. It's making me feel really grim, and actually, it's spread onto both sides now. I was like, bilateral pericoronitis? That's a bit weird. And they said, do I need to keep taking the antibiotics? And I'm like, no, not if it's spread. So I looked in the mouth and
That's not
yeah, she had
working.
bright red tonsils. And I just said, I think you've probably got a viral infection. I think you need to go and see your
Yeah.
GP. So the story I didn't work for, because this was when I was only working 1 day a week. So they went off to see. On the Monday morning, they came into the practice again. Saw one of the other dentists, got a prescription for amoxicillin. 3 days later, came back again and saw another dentist. But by this point, well, Wendy being Wendy had gone off and had a look through the literature, thinking bilateral pericoronitis. I've not heard of that before. It seems a bit strange. So I looked it up and it said it's really related to glandular fever. So I'd emailed the other clinician saying, look, do you think we ought to be contacting her and really suggest checking that she's been to see the GP like I recommended? And they went,
Yeah.
oh, she's already had amoxicillin from us. And so the guy who saw her on the day she came in, the same day that I emailed, he said to her, oh, he goes, we think it may well be viral, like Wendy said on Saturday. Have you been to see your GP? And we think it might be glandular fever, for example. And the mum sat in the corner for the 21-year-old patient. Mum sat in the corner and went, "Oh, I've just recovered from glandular fever." And so then the dentist is like, "Why on earth did you did you
Yeah.
not listen to the dentist when she said your antibiotics aren't working? Go and see a GP for something else." She said, "Oh, well, because I like going to the gym and I thought the GP had told me I couldn't go to the gym, so the antibiotics would be able to mean that I could go to the
Brilliant.
gym." You're like, "Oh." So yes.
But you've led nicely onto
Mm.
metronidazole there, and just before we kind of wrap up, I think for me, I have a bit of an issue with metronidazole being the first line treatment for pericoronitis, because I was certainly always taught that any dental infection is usually polymicrobial, and because metronidazole is anaerobic specific, it is that of help on its own for an oral infection. Or I don't know if you'll know, but what's their rationale behind that?
Only that there's some studies around it. I don't know whether it's ever been studied one drug versus another drug. I've not seen any literature on that. I was in the literature the other day on stuff, but I've not seen one versus the other.
Okay.
What I do know is that again. pericoronitis is usually sorted out just by irrigating underneath the gums and giving them lots of...
Yeah, I mean, that would be the first line, but certainly, if it says they come back and there's some evidence of systemic infection, consider metro. And it's just always, I've always thought, I just have a bit of a with that, but maybe that's just
well,
just
I know,
me.
again, that Scottish group that we were talking about, the Health Improvement Scotland, I know that they are looking at metronidazole because there's quite a lot of resistance. One of the biggest areas of increasing resistance to antibiotics is metronidazole resistance.
Oh, okay, that's interesting.
And so they're looking at what the alternatives could be and should be. And I think that they were considering at one point whether to go with clindamycin or... Yeah. So in America, what they've done, I said that they've swapped away from clindamycin as their second choice drug. They've gone to cephalosporins as their second choice.
Right. Okay. Because I mean that's the other thing. They say, the guidance says if your patient's allergic to penicillin, give them metronidazole. But if you were treating that infection with penicillin, you were treating it with penicillin for a reason because of the bacteria. If you then switch to metronidazole, you're targeting a completely different group, aren't you? So that's always astonished me a little bit as well.
Yeah. So anything that isn't penicillin is a less good choice. And there are studies. So even for penicillin allergic patients, there is studies that show that they have a worse outcome from antibiotic treatment than if they'd been given a penicillin drug. And very often the people who say that they're allergic to penicillin or think that they're allergic to penicillin actually aren't. There is a school of thought that says you should just give them penicillin unless you've actually got evidence that they have.
See what happens. I mean, you get the patients, they're always, what happens? I get a bit of diarrhea and vomiting. It's probably not an allergy, is it? But you just don't know. And it would just be my luck that I had that with a patient who said she was allergic to lignocaine and I didn't believe her and she was.
Oops.
So,
Yeah, so
I did look a bit of an idiot.
The reason I bring this up is that the World Health Organization is doing an antibiotics handbook and they have a dental chapter in it that's they're actually open for consultation at the moment on this draft. And at FDI we saw an early draft. The early draft was dreadful, but the current draft is let me say it's slightly better.
Okay.
The first draft would have, if we had a first year dental student submitting that as an assignment, they'd have failed. It was really that bad. Every single sentence had something wrong with it. It was awful. The current one isn't great, but it's better than the first draft was.
Okay.
But in there, and our big point of principle was that they said they weren't putting any alternatives to penicillin allergic patients because so few penicillin allergic patients are really penicillin allergic. And FDI's perspective is that if you're giving someone an antibiotic in dentistry, it's because they really need one, and it's very close to a lot of vital structures, and you really don't want those infections going places quickly, and you also don't want more inflammation from an anaphylactic reaction. So, you're making an ill patient iller by doing that. We're going back on that at the moment, but it is interesting. I suspect we've already been round the boy once with World Health Organization. They weren't for moving last time.
Okay, we'll wait with anticipation then. Well, Wendy, it's been an absolute pleasure. And for those listeners that don't know you are very active on Twitter. It must be glued to your glued to your hand because every time I tweet you just respond so quickly. So it's been an absolute pleasure. Thanks for spending time with me, having a chat about everything antibiotic wise, and it's been really interesting hearing your career pathway as well, which I'm sure many people will be very envious of, and I'm certainly envious that your PhD is ticked in the box and mine isn't yet. So thanks very much, and I hope to speak to you soon.
It's been a pleasure.